I'm Laura Gerald, president of the Kate B. Reynolds Charitable Trust in North Carolina and vice chair of the board of directors for Grantmakers in Health. I have the honor and pleasure of introducing and moderating our final session of the Fall Forum. We have an esteemed panel assembled today and a timely and relevant theme as we approach the 40th anniversary of Grantmakers in Health. Our panel will explore the past 40 years of GIH with a focus on the future, and we will culminate this session with a review of GIH's soon to be released strategic plan by our president and CEO, Cara James. She is joined today by two of her predecessors, our beloved Doctors Leroy and Mitchell. Although you have hopefully become familiar with Dr. James during this forum and other GIH activities, I'll offer a brief introduction of our other panelists. Lauren Leroy is a strategic advisor to foundations, nonprofit organizations, academic institutions, and government agencies focused on health and policy issues. Her current professional interests and activities include advice on organizational positioning and health-related programming, policy and strategy, executive coaching, and facilitation of high-level meetings and policy forums. Previously, Dr. Leroy was president and CEO of Grantmakers in Health for 15 years, from 1998 to 2012. Dr. Leroy is a member of the National Academy of Social Insurance, a fellow of the National Academies, has chaired several Institute of Medicine study committees, and is senior fellow at the UCLA Luskin School of Public Affairs. She holds a doctorate in social policy planning from the University of California, Berkeley. Faith Mitchell is an Institute Fellow working with the Center on Nonprofits and Philanthropy and the Health Policy Center at the Urban Institute. She is also developing the Urban Institute's American Transformation Project, which will look at the implications and possibilities of this country's racial and ethnic evolution. Over several decades, her career has bridged research, practice, and social and health policy. Previously, Mitchell was president and CEO of Grantmakers in Health for 7.5 years, from 2012 through 2019, and was the VP of Programs and Services for 5 years before that, for a total of 12 years at GIH. Mitchell has a doctorate in medical anthropology from the University of California, Berkeley. She has written and edited numerous policy-related publications and is the author of Hoodoo Medicine, a groundbreaking study of Black folk medicine, and The Book of Secrets, Part 1, a semi-factual supernatural thriller. Welcome to Drs. Leroy and Mitchell, and of course, to our own Cara James. Now, we'd like for this discussion today to be conversational and interactive, as our fall forums usually are. That is a bit challenging to reproduce virtually, but we want you to be able to participate in the conversation. So please drop your questions in the chat, and I'll do my best to ask those for you, or raise your hand to ask a question of the panelists yourself. So let's get started with the questions. And I have to start, I think today, with external context. It strikes me that each of you in your tenures coincided with truly transformational national and or even global events. Lauren, the US experienced 9/11 during your tenure, for example, when you were president. Faith, you led us during the debate and ultimate passing of the Affordable Care Act. Cara, not to be outdone, you onboarded at GIH during the worst pandemic in modern times. And needless to say, we have also experienced unprecedented collective awareness of racial injustice and unrest. So for each of you, I'd like to know how current events shaped or changed GIH, if at all. Let's start with you, Lauren.
Thank you. I'm glad that at least Faith had something positive as a major development when she began, although a huge challenge nonetheless. There were a number of things that sort of set the context for the work that we did in those years, 20 years ago. As you said, 9/11 occurred 2.5 years after I arrived at GIH, and along with the shock and what that sort of led to, there was the public health crisis associated with that, and the recognition that it was not only 9/11, but it was everything that came after that, with the anthrax attacks and the fear of domestic terrorism, et cetera, that the public health infrastructure was not in a strong condition to be able to respond to that. And so there was a tremendous amount of discussion about strengthening the public health infrastructure, which sounds very familiar to us today, which suggests that we didn't accomplish everything we should have back then. Then also, I had the good fortune when I first arrived, really on my first week at GIH, of having President Clinton announce the goal of ending racial and ethnic disparities by 2010 as the major goal of Healthy People 2010. And we were invited to partner with the administration on a number of activities to try to further that goal. And it gave a great opportunity for us to really sort of put that issue on the agenda of health philanthropy. Given what we're going to be talking about, I assume later in this conversation, and what you've been talking about over the last few days, and what Alice Chen documented in the Fall Forum lecture, we haven't made the progress that was expected when that, sort of very serious but stretch goal was announced. Also, very briefly, the growth of conversion foundations, it started before I came to GIH, but it really took off during the time that I was at GIH. And I think it shook up philanthropy in a lot of ways. These were different kinds of organizations. They had a very controversial birth, and so often they focused more on effective communications to try to sort of inform the public about what they were doing, and had a sense of accountability that we hadn't really seen in traditional philanthropy. So that was something exciting and something to take advantage of. The uninsured were growing, and there was growing interest in trying to address that problem that ultimately led us to the ACA. We were very concerned when the IOM's report came out on medical errors and patient safety, and how many people were dying who, from preventable kinds of incidents. Overweight and obesity. I imagine that most people in philanthropy have seen the CDC maps that show the whole country becoming more and more overweight and more obese. And so that was another major issue at the time. In terms of global, unfortunately, and Faith can attest to this as well, there wasn't that much interest. There wasn't interest in doing any kind of funding outside of the borders. And in some cases, foundations were restricted from doing that. But also, there wasn't much interest in learning from what others were doing around the world, even though there were a lot of terrific models addressing healthcare issues, poverty, tobacco, and others. And that was one where we really couldn't get the traction. And the same, I would say, aging and mental health were just beginning to percolate, and I think took off more. We made some progress, but they really took off under Faith. I'll stop there.
Okay. The ACA was passed actually when Lauren was still president, but then activities just accelerated during the time of my presidency. It was a very instructive period for us, because I think somewhat naively, after the ACA was passed, we assumed that all foundations kind of shared the perception that this was a really important step forward. I mean, GIH recognized it as such, but then we rapidly, realized that it was an issue that was perceived politically by some boards, and therefore they didn't want their foundations to get involved. And if you look back now, in retrospect, you realize it was maybe some of the beginning of what we see now, where things that we might see as health people, like a COVID vaccination, as just being a good thing for health, is perceived politically and acted on in that regard. So we had to really tailor the messaging that we used to, and we encouraged foundations to get involved with ACA implementation because we saw it as a way to improve local health. But we really found that we had to tailor how we talked about it and to be sort of sensitive about our messaging. And we got involved with people who were specialists in messaging to help us. And ultimately, one of the lasting lessons of that was that it really brought home kind of the diversity of views within health foundations across the country, and that GIH needed to be very, sensitive and adaptable to that. And there were some lasting lessons about boards and the role that they play in decision making, and just understanding that we needed to do a lot more board education than perhaps we had realized before then. Some other issues that we worked on during my presidency were health disparities and health equity. So that work had really started under Lauren, as she said. It really just continued to pick up speed. And whereas the language was like health disparities when I started as VP, then it evolved into health equity. And then, as we know, even how people think about and act on health equity continues to evolve. So that is a very dynamic area. And then, as Lauren pointed out, interest in behavioral health, sort of mental health, behavioral health, really accelerated during my presidency. I think sad to say, because there were a number of shootings and other kinds of events that really just kind of brought those issues to the fore. But whereas there had been a handful of foundations, of funding partners who were engaged in that work, when I first came to GIH, that number just steadily grew.
There hasn't been much going on since I started at Grantmakers In Health. Now, I mean, clearly we are in a moment we have not seen, and it is really interesting, to hear both Faith and Lauren talk about what were the issues and challenges, which I know we're going to talk about what hasn't changed. And so clearly, as we think about public health, that is one that we are seeing what a strain we have and how woefully inadequate our system is, and how we have not done a good job of maintaining that. I think Faith's point about some of the divisiveness that we have seen and growing in that, we clearly have really a challenge and an attack on health information and what we perceived before as the trusted sources of information are now being questioned with everything. And that is really, I think, sowing the seeds for some real challenges that we're going to have going forward, because you can't take that back when you disrupt the credibility and trust of our public health institutions and those individuals who are the experts. You can't put that back for the next event. So that will be something we know we are going to have to deal with going forward. I think similar to what Faith said in terms of the passage of the Affordable Care Act and where we thought philanthropy was, I think the conversations around racial equity and health equity of the past year and a half have also shown that, like the rest of the country, we have quite a continuum that philanthropy is on, in which some are very much at the forefront and have been doing this for decades, and others are just beginning that journey, and still others are kind of not really seeing that this is as big of a need for work that we have. I think that those are a couple of the things that I would just sort of lift up as some of the long-lasting issues we're going to be confronting. And then I would say that we have also seen that, and we're going to talk about this, the world of philanthropy has changed. So we have a lot of different actors in this space now who may not necessarily think about foundations or approach the work in the same way. And how do we connect up and work with those organizations to really advance GIH's mission and improve the health of everyone in our country. So I think those are a couple of the things I would lift up. I know obviously mental health. We really focused on that this week as part of the fall forum. We know there are going to be continuing needs, and that's another system which is not really prepared to address the needs that we have. So, and one last thing I will say, workforce. So what does our philanthropy workforce look like? What does our healthcare, public health workforce, and interlaced with the need to diversify that workforce to make sure we're being culturally sensitive and appropriate.
I'll warn you, we're going to dig a little deeper on several of these topics. I know that a lot of the external issues that you all have discussed, whether it's public health infrastructure or access to care, including mental health care, these are things that are at the intersection of philanthropy and often direct service delivery, but also health policy. And so we're going to dig a little deeper on that, and also touch specifically on health equity and on boards. I heard you, Faith. That's where a lot of the rubber hits the road. But let's start with the policy landscape over the last 40 years since GIH opened its doors. Again, we've talked about a number of the biggies: the Affordable Care Act, the Health Insurance Portability and Accountability Act, the HIPAA. We've also had EMTALA pass, Emergency Medical Treatment and Active Labor Act. We've had some attempts at mental health parity. How do you think philanthropy has engaged specifically in policy during the times that you were the president? I can imagine that has evolved somewhat. So let's start again with you, Lauren, to see how funding partners were engaging in philanthropy during your 15 years.
When I arrived at GIH, I think it was a turning point for the organization. Prior to that time, there had been an interest in policy, but it was different. It wasn't so much trying to encourage foundations to engage in policy. And I say this not having been there, but this is my perception from what I know, but more to inform, to bring funders together, to hear from people from the policy world, and then to go back and do whatever with that information, but not really to engage in action. And I think part of the reason why that changed, and part of the reason why I ended up getting the job of CEO as opposed to others, was because I came from a policy background, and the board had changed a lot at GIH. And when you talk about foundation boards, maybe there's something to learn from what happened at GIH. As the conversion foundations became more influential and they developed relationships with others in the field, they began to rise to positions of prominence, and a number of them joined the GIH board. They were looking for something different, and it had more of a policy focus. So I came in having a backing to try to encourage that, and we did. But in those early years, there was quite a bit of resistance, and the resistance came for a variety of reasons, but one of the major ones had to do with the fact that many foundations felt that it wasn't appropriate or legal for them to engage in policy-related activities, because there was this association between policy and direct advocacy, as opposed to broader advocacy. You know, foundations cannot advocate on a particular bill, but they can obviously fund and engage in advocacy around different issues. And so there was a lot of education that needed to be done. And that's really the way in which GIH first got into this. And we kept bringing it back and making the fall forum more and more policy focused. And then we had 9/11 and the Great Recession that followed. And for the first time, all the things that we had been sharing with funders for several years before then began to take root, because they realized in many cases that without engaging in policy, they were not going to be able to achieve their missions, to achieve what they wanted, that systemic change was a strong component of their overall strategy. And they came at that point asking for support, for technical assistance, for opportunities to talk among themselves. And that's really when the policy engagement took off. Clearly, it's still an area that some funders have embraced fully, and others stay, arm's length away from. But it's a very different world now than it was. And clearly the work on the ACA and our forming the CEO working group on access and coverage and encouraging more CEOs to join that was another example of how they began to engage in policy in a very serious way. So those are a couple of examples I'll give.
Yeah, to continue the story, Laura, during my period, it really was kind of just an amplification, I would say, of what the ball that Lauren helped get rolling, and the ACA gave an increasing number of foundations an opportunity to either sustain their activities in policy or to kind of dip their toes in the water, especially around issues like Medicaid expansion, things that were relevant to place-based foundations. We saw a number of the conversion foundations getting involved in issues like that. But as Lauren pointed out, it's not everybody's taste. And so many don't get engaged. And the interesting thing is, Lauren was making the distinction between advocacy and policy. We had to continue with that message. I mean, I think it's also because it's something that boards struggle with. And so there's like just a continuing education need to help funders understand what they can do and where the limits are. And then in the last few years, some of the foundations have started up 501c4s, the ones that are really get aggressively interested in pursuing policy issues. So that's a kind of evolution that GIH witnessed and was part of over the last few years.
The one other point I forgot to make that I think is important is that foundations over the time that I was at GIH and beyond, have become very metrics oriented, and policy is messy, and anybody's influence on policy in most cases is very hard to measure. And the fact that it can't be evaluated was something that foundations really struggled with. And there were some good pieces of work that came out of that struggle when foundations began to talk about how do we measure our impact on policy if we're going to invest in this. But I think that's another one of those sort of, makes some funders uneasy because it's really hard to measure.
Cara, what about now?
Yeah, it's interesting. Nothing new under the sun. I think we are still in the same space. As a matter of fact, last year at our fall forum, we had this exact conversation about what is it that philanthropy can do and health funders and how they can engage in policy to break down some of those perceptions and misperceptions about what funders can do. I think that in the conversations I've been doing as I've been assuming the role and getting to know some of our funding partners over the past year and a half, there is very much a range, and some who as I said, are really charging ahead and trying to engage in policy, as in others who are not really where they focus. I think clearly my background coming from the Centers for Medicare and Medicaid Services, policy is important to me. I'm trained in health policy. So I think that, it is important because no matter what funders are trying to work on and improve, policy, be it local, state, or federal policy, has an impact on the programs and the communities that they're trying to work with. So I think even if not necessarily engaging in changing policy or advocating, understanding the impact of policy on the programs is really an important thing for our health funders to know in order to be effective in the goals that they're trying to achieve. And it is work that, as we all know, takes time and is a little messy.
So it's interesting. I was going to ask sort of where you think we might need to go in the future, but I think I have heard pieces of that. You talked about being able to discern the difference between advocacy and direct engagement on bills, and that there's more space in advocacy than we may have thought. And of course, Cara, you're saying, and I'm sure everyone is saying that in order to reach our goals, kind of regardless of what goals we may have as individual health funders, hard to get there, hard to get to those goals without involvement in policy. So I would think that this is part of GIH's DNA for the future. And Cara, I'm sure you're going to tell us a little bit more about that as we get to the latter part of the session. But I'm struck by the fact that, again, we've talked about boards, and I want to go deeper there because there is often a tension between, say, what we as staff or actors might see as our mission and route to that mission, and what the boards that we're working with might see as appropriate directions for organizations. In fact, this week we had a whole session on board engagement as it relates to health equity. And there were a lot of challenges and approaches that were discussed in that session. It was excellent, but I would ask each of you, and I'll go in reverse order this time, what are you seeing as some of the greatest challenges when it comes to philanthropic boards? And we'll start first by thinking about it from a funding partner's perspective. What do you think funding partners are encountering as it relates to their boards and perhaps tensions, again, in approaches that we may think we need to take in philanthropy versus where boards are?
So I guess if we're going in reverse order, that's me. And I was kind of hoping to continue building off of everything that Faith and Lauren said. But I think, from the conversations that I've heard, clearly in the equity space, we're hearing from our funding partners about the challenges of the boards not necessarily themselves understanding what health equity is, or understanding the roles that the funding partners could have in advancing programs and policies to impact equity. I think one of the other challenges that we've heard is every, foundation is different. And so board tenure and turnover is also a challenge that we're hearing in some cases, where you have people who have lifetime appointments or so, and that can also be a hindrance in terms of trying to advance some of the work that people are doing. So those conversations where people are kind of, waiting that out, which also makes it hard to diversify your board, to bring in some of those other voices who could help to move the agenda forward in whatever direction that may be. So I think these are just a couple of the challenges. Again, boards are made up in many cases of those community members. So in some cases where there may not be as, robust trying to get people with the skills and the expertise that you're looking for can also be a challenge in some cases. So those are a couple of the ones that I would sort of lift up at this point.
Yeah, echoing Cara, and Cara, you'll see over the years, you'll visit, once you can leave your room again, you'll be visiting lots of boards if your experience is like mine. And what I felt was, as foundations take on kind of more and more complex issues, whether it was the ACA or health equity, it just really kind of brought more and more to prominence for me how important it was to bring boards along and how difficult that is. Because especially with conversion foundations, which, was majority of GIH's constituency, the boards can be very disparate in their makeup, meaning, you can have one nurse and maybe a doctor and someone who owns a car dealership and a local lawyer. They come from such a variety of backgrounds. Many times there are few health experts. I've talked to boards where there was nobody who really had a background in health. So that part of the board education effort is even just to expose them to understanding that health is more than, say, going to the doctor, and talking about things like the social determinants of health, much less than concepts like health equity. Another challenge is that they have usually there are people who are working, so they have kind of limited time and attention to absorb new information. The staff, only has a limited amount of their time, much less an organization like GIH that might want to intersect with board members and contribute to board education. And then, as Cara said, they may or may not be representative of the community, so that you can get these kind of funny mismatches where the board is kind of made up of one type of folk, but the community is evolving in other kinds of ways. And the foundation staff and CEO are usually well aware of the way the community is evolving, but the board may not, may not have those exposures. And so that just increases the challenges for staff who are trying to, say, move into a grant making area like equity and help board members understand what a concept like equity means. Interestingly, since leaving GIH, I'm on a foundation board myself, the Langloth Foundation, which I enjoy immensely. And they do a terrific job of board education, which is just basically providing opportunities for us to interact with their grantees. And with COVID, ironically, that's become easier because that's just organizing like a large Zoom call, and the grantees are there and we get to hear from them and ask them questions and so forth. And I would recommend that for other funders to think of, because it's just been a really rich experience for me. And I often think of GIH when I'm in those meetings. So let me turn it over to Lauren now.
Hang on, Faith, you're getting a shout out from the Langford Foundation there. Thanking you for your service. And I hope you all didn't miss it. In that discussion that we had, our good Unique Redwood of the IF Foundation talked about their diversity matrix and how they're literally looking for lived experience like homelessness within the last 5 years, or lived experience with underemployment for a significant period of time, to try to diversify their board in very specific ways. But it takes time to get to, boards with that kind of lived experience. But Lauren, I'm gonna throw you a little bit of a curveball. You had mentioned the GIH board changing during your time at GIH. And so since I know Cara doesn't want to touch this with a 10-foot pole, I'll just ask you to say a bit more about that, how you've seen the GIH board change. It's not just about out there, it's also about how we're changing in here. And what would be your observations about that?
Yeah, I actually think that Faith and Cara could say more about that than I could, because I felt very fortunate. The board, throughout my tenure at GIH, the board was a very dynamic group of people. The one thing I found interesting, I will say this, is that most of the board members were CEOs or in the senior leadership of foundations. And so they were dealing with issues in their foundations from that perspective. And in a number of cases, they were struggling to move their own boards or their own organizations. And so they would come and suggest to little GIH that it do certain things or take on certain issues that they were trying to figure out how to deal with in their own foundations. It was almost like having a little experimental group on the side that could tackle an issue. And I found that, to be interesting, let me put it that way, because the resources of GIH were, paled by comparison to the resources of everybody sitting on the board. But they were trying to bring their boards along, and they were trying to figure out how to make the case. And in some cases, they were looking to see if they could try to do it within GIH, which was fascinating to me. But in terms of how the board's changed, I've occasionally looked at who's on the board now at GIH. I haven't followed it that closely, so I think Cara and Faith could probably answer that better than I could.
Yeah, since you said you didn't want Cara to be on the hook, I can just say.
I will just say for the record, I love my board.
Laura, I don't know if you're on the governance committee or not, but that Osula and I used to work on, coming up with names for possible consideration. And then, of course, there's like a public call as well. But the GIH board is like art and science, because it's, the effort to have racial and ethnic diversity, geographic diversity, diversity of foundation size, diversity of foundation type, diversity of foundation role, treasurers and CEOs and senior program people and so forth. It's a finely sort of crafted group. I enjoyed working with every iteration of the GIH board. They're people who were never shy about expressing their opinions and kind of calling up issues that they thought we should be involved in. We got some of our best lessons learned from working with them.
I see you off mute.
Yeah, no, I will just say, so first I do have to thank the board, because as Lauren mentioned, the GIH board is a lot of CEOs who are extremely busy, such as yourself, Laura, who in the time that I've been here have been incredibly welcoming. I mean, everybody answers the phone or email whenever I reach out. And we have, as you know, done a lot of work just in what we've been engaging with to understand. And I think having that critical thought leadership of understanding philanthropy, understanding, different spaces, but that willingness to engage, everybody is incredibly responsive. And I sort of hope that everybody has that in their board with the expertise and understanding that, yeah, I mean, as Faith mentioned, that matrix that we look at as well, you're trying to check all sorts of things and make sure you have that. And we still have places where we can do better. But I think that, what we do have is a really great group of people who are really committed to the organization and to helping philanthropy better itself as we are trying to get to that better health. So I do think it's changed. It's a really engaging, but we're also looking at some things of what we need to bring to the table to make sure that GIH is really strong.
And I think because GIH is the equivalent of a membership organization, it has funding partners rather than members, but nonetheless, the matrix is different than the matrix that a foundation might use to figure out who it would want to have on its board. So the considerations are different.
Very well taken points. But there must be alignment with the board and the mission and some common understanding of how you come to solve the problems that you're looking to solve. And nowhere is that more necessary, I think, than in the health equity space. And at several points in the conversation thus far, you all have talked about the particular challenges that we face there. And I would just ask, are we making progress with health equity? And if not, what's the problem? What do you think is the problem? Who wants to go first?
I could start. I think, I think about this, and I've been doing, as Faith said, minority health, health disparities, health equity, whatever your term of art is for the day, for a while. I was less gray when I started it. But I think that you have always known that health equity is an uphill battle. It is not easy work. It is one that I think a lot of people who do it are passionate and committed to it. It's not been work that has been well staffed or well resourced for years and decades. But there has been, I think, and I'm sort of thinking and choosing my metrics carefully, because we think about how do you measure impact. So I refer often to the National Healthcare Disparities and National Healthcare Quality Reports, which show that we have improved the quality of care for everyone by race and ethnicity and income, but we haven't closed really any of the disparities in quality of care. But I do think we are getting better in understanding the root causes and the drivers. The conversation that has happened in the last, say, 6 years, and I say this in the clinical world because the social medical sociologists, medical anthropologists have known about the social determinants of health for decades. But the clinical world, I think, is really awoken to that. And that has actually led to a lot of attention, interests, activities, and resources that are working to address those issues. These are not issues that arose overnight. So they're not things we're going to fix overnight. They are going to take time. And when we talk about time and what you do for measuring impact, we are talking about really years and decades for us to really make progress on this. But we need to keep a spotlight on the efforts and the activities, because if we turn our attention from them, we just look at where we were, going back to how Lauren started our conversation with right after 9/11 and the focus on public health infrastructure and some things, and we turned our attention away from that, and here we are. So how do we make sure that in this moment that we're in now, where so much interest and attention is being focused on it, that we keep the spotlight so that we can make meaningful progress and not take our eyes off the ball 5 seconds later because there's a new shiny object?
I'll just jump in. I agree with Cara. Awareness, I would say, is where I've seen progress. I've been working on, name that term, literally for 40 years. Back when I was at UCSF, I taught a class that I think I called Racial and Ethnic Differences in Health or something, because we didn't even have the term health disparities then. And so, the at that time, the issue was so new. I used to do like grand rounds where I would talk to the medical students about the idea that there were things, kind of outside of clinical settings that affected people's health, as Cara said. So that message about like social determinants of health took only 30 some years to kind of sink in. It's a slow process. But at least now there's awareness. I'm on committees that are, healthcare oriented committees where people are talking about, the need to collect racial and ethnic data in clinical settings, and insurance companies are talking about it. Where I get frustrated is that they've been talking for like, some of these conversations are, more than a decade old, and you don't feel as though there's been that much progress in that past decade. And so I guess the secret is, as Cara said, we just can't lose sight of it. Funders have an important role to play, I think, with accountability and just keeping these conversations going and not getting tired themselves, and turning their backs. So whether it's workforce, which you mentioned, Laura, and I'm involved in some workforce projects at the Urban Institute, as part of the sort of health equity picture, or the social determinants of health as another part of that picture. We know it's complex. It wasn't, the problems weren't made overnight. They're not going to be solved overnight. They're tough, they're challenging, but we just have to stay in there, and it's going to be clearly like incremental progress. There's no magic bullets there.
And Dr. King warned us.
Clearly, patience and perseverance are key. But I also, I've been thinking in anticipation of this conversation about, how to address something as big and as deeply rooted and structural as the inequities that we see in this country, and the structural racism that underlies so much of this. And I sort of took a little thing from climate change in thinking about what foundations can do. Foundations all along, even as we, don't see it in the numbers, have been working in their communities to support people who are struggling because of these underlying issues. And yet a lot of what they've been doing, and this isn't a criticism, it's just, sort of expressing the reality, is what I would call adaptation, as opposed to mitigation. They've been helping groups that are suffering under the pandemic, and they are helping individuals, and they are supporting organizations, and they're trying to do their best to build in some resilience for whoever the target population is. But that's very different from addressing these very difficult and complex systemic issues that are being discussed a lot more now, but they can become pretty overwhelming. And, as Faith and Cara were saying, trying to educate boards to the extent necessary to get them to step up and take the kinds of risks that foundations like to claim they are able to take because they are in the philanthropic sector, and to stick with things for the long haul, and to engage in issues that are outside of their comfort zone, and to work collaboratively across sectors. For me right now, one of my biggest concerns, if we care about equity and trying to improve equity, we need to look at what's happening to democracy in America. We need to look at what's happening to the infrastructure that supports democracy. And actually, Laura, one of the things I just saw, I think it was in the Chronicle, was an article about supporting local journalism, which is essential, and the role of the Kate B. Reynolds Foundation in supporting local journalism and bringing, capacity to different communities that have lost their access to good journalism. That's just one example of where foundations can work outside of the health realm, but have a tremendous impact. In the time, of COVID, if people can't get access to trusted information, one of the sources is through the media and through journalism. And so I thought that actually was a great example of being outside of the box. Also, in, I think it was 2015, maybe 2014 or 2015, the Fall Foreign lecture in my name was given by Larry Kramer from the Hewlett Foundation. And he announced the Madison Initiative, which focuses on trying to strengthen the institutions that support our democracy. I know they collaborated with a number of foundations, but I'm thinking if I were sitting in a health foundation, I'd try to figure out, given that has really taken off in the foundation, they've made a major commitment. How can I engage with them and help to further that? Because ultimately, if the groups that we've been talking about, the different population groups, don't have a voice and don't participate, policy is not going to change in any way that will be favorable to them, or even just try to right the wrongs that have been committed that have created the inequities we see in this country.
Awesome. Now, folks, as you can hear, we've got a lot of wisdom and expertise around health philanthropy here. And so I want you to be getting your questions and comments ready. We have one in the chat about mitigation versus adaptation. I think, again, there's a lot of resonance with that issue of whether or not we are, just making conditions more palatable, if we're even doing that, or making conditions that we're trying to fix more temporary. That is a real question here. I struggle with that concern, but anyway, that was a comment from Trevor Thompson about the climate. But put your questions in the chat. We do have some time to ask those of the panelists, or raise your hand. In the meantime, though, I want to pivot a little bit because we're getting close to that big reveal of the strategic plan, and so I want to make sure we kind of review where we've been on plans. I know we've had 4 presidents of Grantmakers in Health. Lauren, I know you helped to usher in GIH 2.0 when you were the president, and Faith, you took us to 3.0, and Cara's going to tell us about 4.0. But in an attempt to sort of know where we've come from here, I want you to first, Lauren, give us some understanding of what you were trying to do with GIH and 2.0, and then I want to hear from you, Faith, about the next iteration.
I think it's probably reflected in a number of the comments that I've made. Bold, strategic, thoughtful, evidence-based grant making, continuous quality improvement, not necessarily waiting for all the data and trying to apply metrics that really don't give you the answers that you want, but being bold enough to do your homework, come up with strategies, begin to implement them, and continually review, assess, and improve. Those, I think, are very important. We were trying to really help the sector be more intentional, more analytic, more strategic, all the things that people in foundations want to be. It's not like it was, something that people don't strive for. We were trying to become a resource that would be one of many resources that foundations could turn to give them the kind of support, whether it had to do with data and analytics, with building bridges with government, with building bridges within the sector itself, creating those kinds of opportunities in those forums, and being as much as we could ahead of the curve or right on the crest when issues were arising, so we could bring them to the sector and encourage them to get involved. I would say that was probably the way we operated when I was at GIH.
And we continued the energy under my administration, especially bringing new ideas to funders. I had come to GIH from the Institute of Medicine, where you're bringing sort of the best minds from research and practice and using their knowledge to inform policy. And so I saw GIH in kind of the same spirit, that we could tap into leading thinkers and then, channel that information to funders to help inform the work that they were doing so that they could always feel like they were on top of the latest issues. So we did that. We put a lot of energy into working with other philanthropy serving organizations. For instance, the Health and Environmental Funders Network and funders. We're working with funders concerned about AIDS, that's the name, and the LGBTQ funders, and lots of other groups like that, kind of in finding different ways to work, almost like in coalition, so that it's like health in all things, just taking the health message to the issues that they were working on. So we did a lot of that. We did a lot of internal strengthening. Just as, as GIH continued to sort of grow financially and in staff size and so forth, just making sure that our internal systems were strong and that the board was strong. That was very important to me. So, because the idea is, you want this to be a lasting organization, so it's got to have kind of good legs on the ground. We continued to work with government, just as Lauren had, and encouraged funders to explore public-private partnerships. And then towards the last years when I was president, as we have mentioned already, just as issues became more politicized, and then with the coming in of the Trump administration, there were several philanthropy serving organizations that said, they didn't want to work with that administration at all. But to me, it was important to say, again, health is in everything. Health is not political, ideally. We will continue to find connections and ways to work with the administration. We're not going to cut ourselves off. And that was part of a kind of larger, a philosophy that was what we call GIH's big tent, just the idea that we don't all have to be in agreement politically as health funders, but we can still find ways to work together to advance health in local communities.
Well, now we have an excellent question in the chat. Nikki Vernick would like to know, now that we're almost 40 years old as a field, what should we stop doing?
First thing that comes to my mind is something Lauren said: stop saying that you're able to take risks if you're not going to take them. Because if you think about it, foundations have almost nothing to lose by taking risks, right? No one's going to take your money. You're not going to lose your position in the community or anything like that. And yet, At GIH, you're in a position to witness sometimes very frustrating, hesitancy about taking the lead on issues. And so that would be my top of mind response.
Something I would add, building on what Faith said, first ditto to everything that Faith said. But I think also stop being reluctant to share lessons you've learned, particularly when something you've tried hasn't gone well. We had an experience when I was at GIH. We tried to start a new series where individuals would write up a lesson around a failure, quote unquote. We got as far as one. And even that one, we had to negotiate what ultimately came out of that process. The foundation worked with a writer and then obviously was able to review and edit the work. And in the editing process, we lost a lot of what would have been useful to other funders. And so that was an eye-opening experience for me. So that's one that I think I would encourage funders to be much more open. They can do it in safe spaces. They don't have to, put it out in the Chronicle of Philanthropy, find ways to do it. But, let's not repeat mistakes over and over again.
Laura, I have another one. So don't take this personally, Lauren. I think foundations should stop relying so much on consultants. So this is a real to you. But my sense is, I've not actually done a systematic study of this. My sense is that during that, when Lauren mentioned the rise of the conversion foundation, so suddenly, and it happened very quickly, I could understand that boards might have turned to consultants to help them figure out how should we focus, how should we staff and so forth. But to my mind, there's now just a troubling it's more dependence on consultants for sort of basic thinking. Like just way back when I was at the Hewlett Foundation, we never dreamed of using consultants. You were expected to come up with your own ideas, do your own research, and figure out, talk to people in the field and figure out what you want to do. And so, as I said, my sense is that in some cases, funders have gotten kind of lazy, where instead of hiring the staff who can really do the thinking, maybe, and sort of take the strategic directions that Lauren was mentioning, you just turn to some set of consultants who might, just pull, that don't have the lived experience that we talk about as being so important, and may or may not have the experience on the ground that could really inform the work that the foundation wants to do.
And I
actually agree with that, Faith.
And I think, it's kind of interesting because that reliance on consultants, that's not unique to philanthropy, coming out of government, the reliance there. And I think part of the issue of that is that, which we haven't had a chance to touch on here, but we're not training our workforce to do the work. We're sort of putting them in a position and then expecting them to know how to do the job. And then we used to talk about, sort of when I was at CMS, getting surprised when people would do stuff. But in part, it's because we haven't actually trained people. Some of our PATH programs, the growth programs, development opportunities, those have gone away over time. And we're not really helping people to develop in that space, I think, is one of the things. I think the other thing where we think about, 40 years as a field, what should we stop doing? And this is one that there are some funders who are really taking this to heart, is stop with the program specific funding and allow grantees to use the resources to best meet those needs, which is hard. Because again, we're all sort of looking at that impact. How do you measure impact if you just gave money for whatever was needed, but not necessarily something specific? But I think that continuum of general operating funds and allowing people to pool those resources to best meet their needs is something that we also really need to make progress on not doing as much of.
I have one more that popped into my mind. We could probably do this the entire hour. And that is, I mean, these come out a little strong because we're supposed to be saying what you should stop doing, but nonetheless, stop perpetuating the imbalance of power between the foundation and its grantees or potential grantees. And by that, acknowledge that there is an imbalance and that the funders have the resources that the grantees need. But one should also recognize that without the grantees, the funders can't accomplish their mission. And to be much clearer about that and to create a culture around that in the board and in the staff so that there's real trust in the grantees of the foundations. I read in anticipation of this conversation, because I haven't really engaged at the level of the Grantmakers in Health and these issues in a long time. I did a bunch of reading, and some of the quotes that I read from board members and staff and foundations about grantees really broke my heart in terms of the lack of trust and even lack of respect in some cases. And I think many foundation staff, it's unwitting in a lot of cases. They don't realize sort of how they're perceiving their role vis-a-vis grantees. I think it also then plays out in foundations' reluctance to give unrestricted funds, core support to organizations that can help them advance their mission. And I noticed, I think it was the Center for Effective Philanthropy did a study recently, I think that's where it was, I may be wrong, where they showed that funders changed some of their behavior during the pandemic, their practices. They gave more unrestricted funding. They simplified the proposal process and the reporting. They engaged grantees more in defining what the needs were and in shaping their programs. And there's already a pulling back on that in 2021. A number of funders have reversed and gone back to their former ways of doing things. And I think people should take a real hard look at what happened during the pandemic, how they were able to engage much more quickly, the way in which they worked with grantees, and really, sort of think about what that means going forward.
Wow, such a riveting conversation. We could continue this for another hour, but I know my only real job as moderator is to watch the time. And so we have come to that moment where I will turn it over to Cara. My last question was going to be, since we're obviously perfectionists, I wanted to know where folks thought we should be in 50 years if we were perfect and met the urgency of the moment.
Okay, well, I know we are at time. So thank you, Faith and Lauren, for those questions. And again, thank all of you for staying with us through the end of this conference. I want to again thank Faith, Lauren, and Laura, as well as the 30 other speakers who shared their insights and expertise with us over the course of the week. I also want to thank, as we all know, none of these conferences happen without the support of a team of a lot of people you don't see. And in our case, I really want to thank our team, Allison, who you got to see if you participated in our From Crisis to Care sessions, Meg, Monique, Natasha, Smita, Sue, and of course, Osula, who has really been shepherding this process to make sure that our conference came off without a hitch. Over 120 people joined us this week, and we thank you for taking time out of your schedules to be part of these conversations and to engage with us and our speakers. Just a couple of last minute things. One, you are going to receive an evaluation around the conference, and we encourage you to fill that out. Give us your feedback. Let us know how we can do better in the future. You'll also receive instructions on the slides and how to access those, as well as the recordings from the conference, and encourage you to visit the content that you loved and share that. And finally, as you can see on our slide here, we have a deadline quickly approaching for the Terrence Keenan Leadership Award and the Andy Hyman Award for Advocacy. And we would encourage you to think about nominating one of your fellow colleagues for either of these awards. And lastly, we are crossing our fingers that we are going to be in person in June in Miami at the annual conference. And we hope that you will join us there for our session where the theme is going to be focused on the future. Until then, I hope you all stay safe and healthy and that you and your families enjoy the holidays. And we look forward to seeing you soon. Thank you.